Good afternoon or good morning, depending on where you are. Welcome to another in the series, Machine Medicine's interview series. We are delighted to have Dr. Ro'ee Gilron from the STAR Lab at UCSF with us today. And the focus today, Ro'ee, I think is going to be on adaptive deep brain stimulation. But before we get into the guts of that, I wonder if you would be so kind as to give us a short sort of biopic or bio of where you came from, what you started as in undergrad and stuff, and how you ended up in this sort of area of research.
Sure. Yeah. Happy to be here, Jonathan. Thank you. I grew up in Israel, and I went to undergrad in the States, where I am right now. I'm in San Francisco now, but I went to undergrad on the East Coast in a university called Brandeis in Boston, and I studied neuroscience. It was, by the time I'm fairly young for the field, so by the time I got into undergrad, neuroscience as a concentration actually existed, and I've always been really fascinated by the brain and all of its mysteries. I think it's one of the last frontiers when it comes to human knowledge, and there's so much we don't know, and also so much that we have learned in the last few decades. So I really enjoyed that, and during my kind of undergrad studies, I did a lot of work in neuroimaging, and then continued to do my PhD on that, where I went back to Israel to Tel Aviv University under Ro'ee Gilron, who was my advisor. And I mostly worked on the motor system and the mirror neuron. So essentially this idea that part of the way we understand action is that we actually, simulate it in our brains to a certain extent. And I did a series of studies on that in neuroimaging, but also at the same time, I was working in the epilepsy monitoring unit in Tel Aviv University with Dr. Fried, and we were doing experiments with a lot of these epilepsy patients that were undergoing surgery to resect an area in the brain that was causing their epilepsy. It's a common surgery that is done for epilepsy patients that fail, medications or any other lines of treatment, and has a fairly good success rate. And during this time, the patients spend about a week in the hospital, and during that week, they're just hooked up to all this machinery. There's essentially wires coming out of their head, and you can do not only studies about the epilepsy, but also a lot of other studies, and that's a lot of what I did, and that really kind of made me fall in love in this area of what we call translational neuroscience. So not only basic research trying to understand how the brain works, but actually research that can try and modify the course of a disease, for example. And that interest in stimulation and is what led me to Dr. Star Labs. I still remember, one of the strongest memories I have from the time of my PhD is in the course of this surgery and the hospital stay for these EMU patients. They have all these electrodes hooked up to these patients' brain, and they're trying to really narrow down the area in the brain that's responsible for the epilepsy that's starting this electrical storm that is so incapacitating. And to do that, you have to functionally map everything around to make sure you don't resect an area that's responsible for language or crucial motor function, and you stimulate the brain briefly to see that you're not inducing a seizure. If you are, you know that you're where the seizure has started, or that you're not in a functional area of the brain that controls language. And I remember very vividly, this patient was stimulated in a very particular area in the brain, an area that I now study very intensively, and her hand suddenly moved, but she did not move her hand. And that was the first time she experienced that. And I remember that look of shock on her face. And, we study this in undergrad and in graduate school, but to see a real manifestation of that, of how the brain is wired together, is really powerful. From there, I did, and I'm sure you've seen that as a neurologist as well, in your career. And from there, I went to do, and where I am now, I'm doing my postdoc with Dr. Philip Starr at UCSF. And I went kind of back to the motor system, but in the context of translation. So I'm working with Dr. Starr, who is one of the world's experts on deep brain stimulation for Parkinson's disease. And this is, as Dr. De Ridder spoke about in one of your previous talks, is a motor disorder. So, where you have either Usually it's associated with tremor. So that's what people, mostly think about. They think of Muhammad Ali and that kind of thing. So that's a kind of a hyperkinetic symptom where you move excessively. There's also dyskinesia, these unwanted wiggly movements. But there's also a lot of hypokinetic symptoms, so where you're moving less than you want to, where you can freeze in the middle of walking, where your movement becomes very, very slow. And DBS is not the first treatment that these patients try. Usually they'll take some form of kind of dopamine replacement, because the disease starts from a tiny nucleus in the brain where these dopaminergic neurons, essentially that secrete dopamine neurons, die, and that has wide-ranging effects throughout the brain. We now think of Parkinson's as a network disorder, and you can initially really effectively treat it with medications essentially that help you replace the dopamine cells that are lost. But starting in the 50s and 60s, they discovered kind of in a series of experiments that you could actually take out this diseased area of the brain that is causing potentially pathological oscillations, and that was actually surgically remove it or lesion it, which means you can kind of destroy a small area, and that vastly improved the Parkinsonian symptoms in patients where the medications became less effective. And then in the early 90s, they had this idea, when the pioneers was Dr. Ro'ee Gilron, who was also in Israel, of instead of irreversibly taking this small area in the brain and lesioning it or destroying it, you could put a little electrode in there and create what we call a reversible lesion. So the idea that you could tune a lot more, fine tune, what you're doing to this small area in the brain. And just the surgery itself, kind of being exposed to that in Dr. Starr's labs, is kind of mind-boggling. You're trying to hit a tiny almond-shaped nucleus, in most cases, the subthalamic nucleus. It's deep in the brain, and it's connected to a lot of other structures in the brain through a tangle of blood vessels. And you have to hit, not only do you have to hit this nucleus, you have to hit a very specific part of it to have very effective treatment. So that's deep brain stimulation that has been going on since the 1990s. And there have been, I think upwards of 200,000, maybe 300,000 patients by now worldwide that have received this therapy. And it's very effective, and it's almost remarkable how effective it is that, this crude stimulation could, really vastly improve symptoms control for a lot of these patients. Another one of the kind of really shocking moments for me was to see how improved that is, where, you're sitting in the clinic with a patient, and after the surgery and after a neurologist has programmed and tuned their stimulation to be, precisely where it needs to be, in the right contact and the right frequency. And you see someone that has, uncontrollable tremor, and you flip a switch and it's gone. And it's literally within a few seconds. And that's also
remarkable, isn't it? It is
it's pretty remarkable. Yeah.
So let's maybe dig down that into a bit. So it'll doubtless will, be a familiar sort of fact to you, and perhaps even to me to some extent. But to many people, as you mentioned, it'll be sort of prima facie very surprising that you can stick a fairly sort of coarse electrode into neural tissue and affect something which is apparently such a sort of symphonic sort of control feat as motor function in human beings. It's kind of, I think I heard Elon Musk the other day on talking about neural links say that, at the moment we're kind of kicking the TV, and yet, just as kicking the TV sometimes does work, it seems to work. Is this sort of, what's the intuition behind why this does work?
Well, I think, there's been a lot of people that study this to much greater degree than I do, but I think that to a large extent, we're thinking more and more of these disorders as oscillopathies. So essentially, if you think, of a symphony, if your brain being a symphony with 86, some billion neurons, they all need to talk to each other perfectly in the right time. And in a lot of these disorders, if it's epilepsy or if it's Parkinson's, you can have one instrument or set of instruments. Maybe it's the wing instruments, or maybe it's you can think of them as it's maybe just a drum that is drowning out everyone else.
Yeah.
So he's banging his drum really, really hard, and I think that in a lot of these disorders, the reason it's so effective, this crude stimulation, is this guy who's kind of ruining it for everyone by banging it out. You can target that one area in the brain and tamp that down so that the normal communication can recover. So I think that's, Dr. DeRitter talked about this difference between enhancement and changing kind of stimulation in your previous series. And I think that's, a very apt analogy. If you're trying to kind of prevent someone from speaking, that's a lot easier when it comes to these crude electrodes compared to actually fine-tuning a specific neurobiome to produce an experience, for example. So I think that's one of kind of the lucky reasons. That being said, I think we're also very lucky in movement disorders because there are now trials trying to adapt neuromodulation to a lot of other disorders, and it's a lot more difficult to do.
And yeah, you're right. We did touch on this with Dirk a little bit, but I think one of the sort of thoughts that we alighted upon then was, well, maybe in those situations, it's not just this kind of destructive interference that's required, but actually a kind of creative interference. So you have to establish a new pattern of sort of healthful activity, which may and certainly sounds sort of plausibly would be much more difficult.
Yeah, no, that's true.
So that kind of brings us on to sort of one of the sort of things that you mentioned before about adaptive DBS. But you mentioned initially that, of course, the first thing you have to do is choose the right patient, obviously, that has the sort of appropriate diagnosis. But then you have to get the electrode into the right place, and you mentioned that can be extremely challenging because the target volume can be sort of like 1 or 2 cubic millimeters, I guess, right, in terms of how accurate it has to be, maybe even less. But you work in an area that takes a slightly takes the next step, I guess, and so that's what's the thought behind adaptive DBS and which is the particular area that you focus on, if I'm correct.
Yep, sure, yeah. So DBS, as I mentioned, is extremely effective for these Parkinson's patients, for a lot of them, but not for all. There are some limitations there. And I think, one of the problems is that, these patients, specifically in the case of Parkinson's, they fluctuate throughout the day. So their symptoms are not always the same. It's not that they always have tremor or they're always, slowly moving. They take medication to help, with these symptoms. And the medication, one of the reasons they get these deep brain stimulators are less effective in that, each dose gives them benefit for less time, and then the transitions between being medicated and not medicated is also pretty extreme. And these fluctuations continue after deep brain stimulation, even though it helps with a lot of their symptoms. And sometimes they can be so severe that it can interfere with therapy, so that you're not getting the most effective dose of stimulation because you're limited by these fluctuations. For example, if you're very, very slow, you can give someone stimulation to make him a lot faster, but then his medication will kick in. It interacts, these medications and the stimulation, they both have an interaction on the brain, the chemical side of the brain with the medication and the electrical side with the stimulation, and they can produce side effects that are unwanted, like wiggly extreme movements. So that's one aspect. Another big aspect that our lab and others at UCSF are looking into are also all the ways in which deep brain stimulation is not effective for some of the Parkinsonian symptoms in particular. So, Parkinson's is known as a motor disorder, but there are many other aspects in the motor kind of behavior that aren't well controlled by Parkinson's. Freezing of gait is a really good example. They can walk through a doorway and kind of just freeze, and that's not well controlled with deep brain stimulation. And there's a whole host of non-motor symptoms, issues of motivation, anxiety that are associated with Parkinson's, depression. So sometimes those can be even more debilitating. And the small nucleus that we're hitting actually controls, all of these, is associated with all of these symptoms. And it's possible that with, smarter, deep brain stimulation, we can try and interact with some of these other subsystems and address either side effects or other symptoms that aren't now well controlled with deep brain stimulation.
I see. Cool. One of the themes of your research also seems to be, as I understand it, the importance of feedback, and of course, there's various different kinds of feedback that you might use. You mentioned, the side effects that people might have, and I guess other clinical sort of features. Such as motor performance. You look at cognitive performance. Is there cognitive performance impaired? And also you might actually record the neuronal activity locally with the device itself. So can you say a little bit about those different sort of possibilities and which you think the sort of where you would put your money, or would you spread it evenly?
Sure. Yeah, so I think that we're really on the cusp of a revolution when it comes to neuromodulation. And a lot of this is because of a new crop of sensing and stimulation devices that have come on the market for deep brain stimulation. The first commercial one actually just came out a few months ago. It's the Persa from Medtronic. But we work with experimental deep brain stimulation devices. And what's unique about them is that previous deep brain stimulation devices, they could stimulate the brain, but they couldn't sense what it was doing. So it's, if you think of a heart pacemaker, they're very sophisticated now. They can sense if you have an arrhythmia and a irregularity in the way the heart beats, and then they can respond to that. And the deep brain stimulation devices until now have not been able to do that. But recently, these new research devices, and actually there's two commercial devices, NeuroPace is the other one I'm just remembering for epilepsy, they can do sensing. There's these new crop of research and commercial devices that can now sense the brain activity and react to it. And that's a game changer and how we are able to really address this. I like this example that Helen Bronte Stewart gave once. She was a kind of famous neurologist in this space, where it's like trying to treat blood pressure without being able to measure blood pressure, right? We've kind of been flying blind all this time. So it's a really exciting time to be able to do research, and I think one of the critical pieces here is how do you, what do you sense? One option, obviously, we talked about is the brain, but there's many other things that you could sense. I use wearables extensively in my research, and how do you make sense, of all this new information coming in? How do you make decisions about how to modulate the brain? Those are all really big questions that are really difficult to do. So I think not only in movement disorders, but in a lot of other disorders, there's a lot of efforts on this front, and it's kind of really undergoing a revolution. The field.
Yeah. So there's invasive sort of ways of monitoring, such as local field potentials. You said that you can record from the device itself, commercial and research devices. There's also sort of non-invasive, like the wearables and stuff that you mentioned. But let's talk about the invasive ones a little bit, because that's sort of interesting. I understand that in your more recent research, you're working on sort of maybe I could call it sort of slightly more extensive implants that enable you to record from sites that are distant from the actual stimulator itself. So, obviously there's going to be a limit to that, right? I mean, you can't fill the head with bits of metal, but perhaps you could talk about the motivation for thinking, well, maybe we should do a little bit of this, and this might be a fertile thing to do.
Sure. So deep brain stimulation devices, like I mentioned, they target a very specific area in the brain with decades of research that tells us that's where we want to stimulate. But now that we can sense, then we have the opportunity to look at the brain as a whole. The brain doesn't. It's not this one little piece that if you touch it, it doesn't affect everything else. Any area you stimulate in the brain, you'll be able to see the effects of that throughout the system. And small nucleus controls our movement. It's involved with the brain controlling movement. So, one of the main motivations for us in placing, we essentially place another sensing electrode on the top of the brain, in the front, right over here, right over this small area of the brain that, is often called the homunculus. So there's a representation of our body, right over here in the top of our brain, such that, if you stimulated, one specific area, your hand could move. If you went to a different area, it would affect your leg. So, which was, widely kind of described by Penfield, back in the 50s. And I think, so we implanted another electrode there. It's another node in the network. And our lab has, over the years, has discovered that you can sense, a lot of these issues with, Parkinson's, for example, from this other node. And why do we do that? Why stick more hardware in the brain? One of the main reasons is that it's extremely difficult to stimulate in one little area of the brain and then sense from the same part. It's a very hard challenge to do because there's a lot of interference from the stimulation. Another reason is that there are signals that you can actually sense well in this, small node in the brain, and there's, other signals that you could sense very well on kind of the top areas of the brain. So I mentioned those wiggly movements, which is a really common side effect of Parkinson's. There's a very nice signal that we can tap into that will tell us about these dyskinetic events, these wiggly movements at the top of the brain, in kind of the cortical, motor cortical regions, and we tap into that in our adaptive stimulation algorithms.
Interesting. Yeah. So your second recorder is on the primary motor strip, and was there a? I mean, I guess there's an intuitive kind of motivation there that it's a motor dysfunction. So maybe that's a good place to sort of record in addition to the deep nuclei where we're all also stimulating. Was there more kind of motivation than that, or was there other evidence that suggested that would be? I guess you mentioned that the dyskinesias can be, that was already established, was it, before you decided, okay, we'll try and record on the motor strip? Because I guess another place you might think there will be information might be the sensory representation in the primary cortex.
Right, and our electrodes actually span that. So now we have two electrodes which are post-central and two that are pre-central. So we actually tap into both of those systems, and there's evidence that there's a functional separation as expected between the two when it comes to symptoms, where we're seeing from some initial patients. And I think the reason this always starts in the OR. So this is work that Dr. Starr did, and Coralie de Hempton, who used to be a research scientist in the lab, is now at the University of Florida, and she really showed that in the OR, you can really sense, other aspects of the, this disorder from, the motor system, which stands to reason, given that it's a network phenomena. And I don't know the, exact motivation. That was before my time here, what actually motivated that initial stream of research, but it really stands to reason, given how all these, areas are interconnected. And that's really what paved the way to the work that I do now, with permanently implanting electrodes. So what's unique about our research, and to say something just about the device that we use, is that it really is kind of unprecedented in what we can learn from these patients, these really these volunteers that are really contributing to our work. Because up until now, almost every study that you looked at that studied these patients and what their signals mean looked at very short recordings of data. I mean, there's a few studies that looked at more, but most of them looked at a minute or two of data, maybe 3, in a really artificial environment in the clinic, for example, or right after surgery where there was a wire coming out of your head. But we never were able to look at what happens when the patient goes home, and what happens to all of his variability. And the device that we have now actually has the capability to stream high fidelity invasive, so inside the brain information outside of the brain to a computer that we give our patients essentially indefinitely. So our patients have recorded each of them hundreds of hours of data as they go throughout their day, some of them thousands. And we're really learning a lot about not only how to sense what these different brain rhythms mean, but then also how to modify the stimulation to react to those stimulation, to those changing symptoms.
Really interesting. And I guess it brings us on to one of the other aspects that I think is really interesting about this area, because of course one of the reasons that we haven't previously been able to record for a long time is essentially technical reasons, right? It's not a sort of a preference on the researcher's part. We've always wanted to have lots of data, and there are limitations like battery lifetime and battery size and that kind of stuff. So it'd be interesting to know for somebody who's maybe at an earlier stage of his career and thinking about what to study, or if this is the right area for him. Can you say a little bit about how multidisciplinary this area is? I mean, there's neurosurgeons, there's research scientists, there's cellular biologists, and what's the kind of the variable? There's a sort of kaleidoscope of different specialties here, right?
Yeah, you really need everyone, and I think a really good example of that is a recent kind of consortium that we formed, our lab and others, called the Open Mind Consortium. And so if you can look it up, the Open Mind, and I think you need to put brain in there to really, because there's a lot of open mind on the web. But, so what it is, it's a collection of researchers that came together from various disciplines to try and disseminate this new technology. And they include our lab that focuses on movement disorders, but also Greg Worrell's laboratory in the Mayo Clinic, which uses the same device that we use to treat epilepsy in a totally different area of the brain. And then there's another lab that's a really big also neurological disorder. We also collaborate in this consortium with Brown and Baylor, that both have a project using, again, the same device that we're using to treat OCD. So, which is kind of a neuropsychiatric disorder. And in all this has to be wrapped around, very stringent quality control and quality management systems. And over there, we're collaborating. And there's also part of this consortium is Tim Dennison at Oxford, which was formerly at Medtronic, which is a company that makes this device. And I think part of why we're in this, really unique place in history is that there's more competition now, and there's a lot more device manufacturers that are now generating these sensing and stimulation devices. And there's experiments underway just at UCSF looking at using either neuromodulation or deep brain stimulation to treat, chronic pain, to look at depression. I know that there's looking at this with obesity. There's another big trial for depression, essential tremor, Tourette. So there's a host of disorders that are now looked at as a candidate to treat deep stimulation. And part of this may be a reaction to the fact that a lot of the big pharma companies have actually shut down a lot of their research activities when it comes to a lot of neurological disorders. I think because billions have been invested, but there haven't been a lot of new candidates, especially when you look at Alzheimer's and other disorders. Stroke are a lot of good examples. So all these areas, it makes sense to try and go to the brain and see what you can do with stimulation. So I think there are so many, you said, different skills are needed. You need, a dedicated team of neurosurgeons and nurses and neurologists to treat these patients and plan these patients. We involve, especially on the initial phases when you're doing these experiments, we collaborate very closely with neuroethicists, which is a really important part of this. And, we also do, research into ourselves and others in the field. And then, there's engineering of that, which is, and kind of neuroscience of that, which is where I come in. But this is one of those cases in science where it's not kind of a lone PI that can do this work. You really need to have, a big team that works on this together and works well together. And then, clinical coordinators, there's the whole world essentially that brings this research forward. And increasingly also there's space, on the commercial side for companies to develop new technologies to help disseminate and scale this technology out.
Yeah. And then an additional kind of individual that we've an additional player that we haven't really talked about too much, but of course one who's absolutely crucial to this whole thing is the patient. And these patients are really remarkable, right? These are essentially sort of experimental procedures that they're allowing to be performed within their cranium, and they do so willingly and for no remuneration. It's kind of it's incredible, right?
Yeah, I think the patients are really the real heroes here. I mean, we work with a very small number of patients that in our area, and it's a very tight relationship. They, like you said, they do for ethical reasons they can't be compensated for this. So they really are volunteering for this work, and they are extremely dedicated in kind of the data collection. They, like I said, the amount of data they've collected is staggering and is likely more at this point than the entire field combined. So we're learning a lot from what they're doing, and we also get to know them really well. We just had this week we had our annual. Usually we have a patient appreciation dinner where we share every year kind of our research and get to meet the patients. Since we had to do it over Zoom this year because of COVID, but it was really nice to see everyone, and we see them every week over Zoom actually. So that one of the kind of happy accidents of this work is it was all meant to be remote because it's meant to test out neuromodulation in the patient's home, in the real world, to really drive this forward. So by doing that, essentially, we were able to keep working despite COVID and do everything essentially remote over Zoom.
Great, yeah, and that's fantastic, and that you were able to keep working. And in fact, you've already published at least a preprint on Archive or something. Is that right? Where can people find that if they want to have a read about what you've up to?
So I hope maybe you'll help me. We'll put a link to that in the bottom here.
Let's do that. Yeah, and I encourage people to look at that. It's really some amazing, sort of amalgam of engineering and sort of neurological, neurosurgical ambition together with software and so forth. So, a really inspiring combination. So yeah, we'll definitely take a look at that and put the link in when we post it on YouTube. All right, we're coming towards the end of our unfortunately, Ro'ee. It's fantastic. I guess as a final kind of final kind of sign off. What do you think we're going to see in the next 5 to 10 years in this area? What are going to be the big breakthroughs? What's going to surprise everybody, or most people who maybe are less familiar with this?
So I think we'll see a lot more of these kind of sensing and stimulation devices. I'm hoping that this will be really transformational for other disorders. So for the neuropsychiatric disorders where there's so much need, I'm really hoping we get a big breakthrough there, because you know, I think it's long overdue, and that's one of the most kind of areas where there's the most unmet need.
Absolutely, I know here. Second. All right, Dr. Ro'ee Gilron, it's been an absolute pleasure. Thank you so much for your time. And as I said, we'll place a link to Ro'ee's paper under YouTube video. And thanks again, and catch up again soon, Ro'ee.
Okay, thank you. Thanks for having me.